case was an 86 years old male who's a long-standing diabetic and hypertensive for almost 30 years, and also chronic kidney disease with the creatinine hovering around 1.8 to 2 milligram percent. He presented with the acute coronary syndrome, inferior posterior MI, LV dysfunction, ejection fraction in the tune of 30-35%, moderate mitral regurgitation, PA pressure in the range of 50 millimeter of mercury. On the basis of clinical background, he underwent coronary angiography, which revealed a heavily calcified critical left main distal with the 3-vessel disease and left dominant circulation. He had been referred for the CABG, but turned down because of advanced age and multiple comorbid conditions. Discussed with family about the CHIP PCI, with the PCI with LV support for the multi-vessel and also the critical calcified left main disease. But family didn't give consent for the PCI. They told that it's a very complex disease, so we want to have a medical follow-up. So he was optimized on the optimal medical treatment. But next subsequent 2 to 3 months, he presented to the ER with the recurrent angina and ischemic LVF with the left main equivalent changes, ST sagging in the precaudal leads and ST elevation in the AVR and V1. And the last time he presented with the cardiogenic shock, acute decompensated heart failure with a systolic BP of 85, heart rate 52. This was late in the evening, and saturation dropped to 85%. And immediately, electrolytes at the time were 5. Discussed with family about the treatment modalities, like he needs hemodynamic support. He was intra-aortic balloon pump was put immediately, started on vasopressors, noted infusion. In next 2 to 3 days, he got a little stable. This was the presentation ECG, ST sagging in the precaudal leads and AVR elevation. On day 6 in the CCU, who got stabilized on IBP and vasopressors, family still opted for optimal therapy. They told that just wean off from the IBP and we want to be on optimal therapy. As soon as patient was weaned off from the IBP, he started decompensating. He went into shock, cardiogenic shock, and developed tachycardia. And then again, we had to put an IBP from the opposite groin. Meanwhile, he developed ischemic stroke also from the right MCA territory. And the neurologist was taken to consultation, and he gave that you cannot operate for next 7 days. So on day 15, discussed with the family after neurology clearance that family had to be told that he needs a PCI, high-risk PCI under MPL ICP support. If we don't do it, it's very difficult to take him out of ICU. Eventually, family gave consent. And then this is the MPL CP from the right groin, and the left side is the 7th guiding. You could see heavily calcified critical left main disease extending to both LAD and circumflex ostium. The circumflex is dominant. There is distal circumflex type disease. And this is the 1.5 rota. Initially left main to circumflex, then to left main to LAD. Ablating both LM to LAD and LM to circumflex, and subsequently with the help of guide extension support, directing the distal circumflex lesion, and the stent was deployed in the distal circumflex. No, he's not here yet. And subsequently IVL from LAD proximal to the left main, 3.5 IVL. With that. All the 8 cycles of 10 pulses each were given from LAD to left main and circumflex to left main, and then this is a mini crush, 4 into 16 DS into circumflex and 4 into 38 DS into left main to LAD. So the mini crush deployed at 16 atmosphere, and subsequently post-dilated LAD with a 375 and 4 millimeter NC, and the circumflex also 4 into 15 NC. Port was done with the 5 millimeter balloon at 22 atmosphere. And finally, it was an excellent result. And this is the snapshot of IS pullback. It's a very well deployed stent throughout the length of LAD to left main and also the circumflex. We can see nicely formed carina at point of confluence. And this is the final angiographic result. Very well deployed stents in both the LAD circumflex bifurcation and also in the distal circumflex. MPLS support was weaned off on the post-procedure on day 1. Vasopressors were weaned off in day 3. And patient was mobilized, shifted to room on day 4, and discharged on day 6. His ejection fraction improved to 35-40%. MR reduced in severity by grade 1, and creatinine also came down. The patient improved, and this is the presentation ECG, and in the bottom is the at the time of discharge. And the learning from the case is a 86-year-old male with multiple comorbid conditions like diabetic, hypertensive, CKD, developed stroke in the hospital with LV dysfunction, and with the critical left main, badly calcified vessels. He deemed inoperable by the cardiac surgeon. The complex PCI with the rota and IVL with MPLA heart pump support has given new lease of life for the patient who has not been able to wean off from the IBP in the ICU. So meticulous planning and the careful execution with the latest intervention devices and the teamwork gives the best results in chip cases like this. Thank you very much.